Oh, Emma, we've lost you. I'm sorry.
On mute. Did I go off then? Can
Yeah,
you hear me now? Okay.
I can hear you now.
Thank you. I'm currently the patron of the Society of British Dental Nurses, and I'm honoured also to be an ambassador for the Mouth Cancer Foundation. Um, I'm also going to talk about obviously the role of us as dental nurses within oral cancer, touching on my role as the Macmillan oral health practitioner that I was a few years ago. Also, I'm going to talk about the elderly. If any of you see me before, you'll know that my passion is with the elderly, having two parents with dementia. So it's opening up a whole new world for me. And I'd like to say it's horrific and it's tough, but it's not. And I'm learning to deal with it. But I'm also looking at mouth cancer and seeing mouth cancer in the over 65s and people with dementia. So if it's all right with you, well, I've got you now. You're not going anywhere. You're going to listen to me. If it's all right with you, we'll touch on that shortly. So let's get cracking. I apologise again if you can only see the top of my head or I look a little bit disheveled. It's all my fault and this PC that's going out the window shortly. So, hang on a bit. It's not letting me go. It's not letting me. Oh, yes, it is. There you go. So, what we're going to do, what's the aims of this session? Raise awareness around mouth cancer, investigate the causes of mouth cancer, and explore the long-term effects of the disease. That's the bit I tend to gravitate to, is looking after our patients after they've been diagnosed, and also the long-term effects of this condition. We're going to look at the treatments available, identify the side effects of the treatment, and reflect on our role, mine and your role, as nurses with poor mouth cancer. A lot of you will know the treatments available and the side effects, I would have thought, but I want to turn it on its head and look at how we can be doing a little bit more as dental nurses. So again, just to reiterate all these figures, it's the sixth most common malignancy reported worldwide. Look at the cases we had in the UK each year. I mean, that's, and it's going up. We're not winning here at all at the moment with mouth cancer. They have a higher proportion of deaths than breast cancer and cervical cancers and skin melanoma. And every 3 hours we do lose somebody to mouth cancer in the UK. We have more deaths in the UK than road traffic accidents. And these two bits at the bottom, these two facts are the ones that get me every time I do this talk. 5-year survival rate has not improved, and nearly 50% of the cases in the UK are preventable. With my work with the Mouth Cancer Foundation, we know we seem to have gone backwards through the pandemic. If we were all sat in a room together, we'd all be nodding and we'd be discussing this. Pandemic hit things, it just turned everything on its head. People were struggling to see the dentist. Again, I'm thinking about care homes. I can't get dentists to go into care homes currently anyway. So we are swimming against the tide, as it were, but we're going to change it, aren't we? Let's think positive. Where do we find it? Tongue. The youngest person I know who's had a tongue out is a 7-year-old girl. I always say that at these talks, and I must sound flippant, but 7-year-old girl, it's horrific, isn't it? It's terrible. Lips, we find it in lips, inside the cheek, inside the gums, roof and floor of the mouth, tonsils, and salivary glands. So these are the areas that we find a mouth cancer. When we go into care homes and we're asking staff to assess the mouth, these are all the areas that we would ask them to have a look at. I have a wry smile with this because I think there's some of us that have struggled to actually look at these areas, and we've been in dentistry, a lot of us, many, many years. I think patients are getting more challenging. I think it's harder to actually assess some mouths of some people, and especially, I keep going on about the over 65s, that group, some of them do have challenging behaviours. My mum being one of them. Why? People who smoke and drink are 30 times more likely to develop the disease. And gupta is very harmful. We've got a big Asian community up here in Manchester, and every November, myself and my colleague Amanda go on Crescent Radio to the Asian community to try and get that awareness out there. We do that annually, and we'll be doing it again in a few more months' time. Tobacco is linked to 2/3 of cases, and a morning cigarette can double the chances. HPV transmitted through oral sex could overtake tobacco and drinking in the next 10 years as the main risk factor. So that's the one that we're all keeping our eye on. You might have seen this in the news actually this week. More than half the cases in the UK have been linked to a poor diet. I know when I was working for Macmillan, you'd have all the risk factors for most cancers would be tobacco, drinking, they sort of intertwined a little bit, sun damage, and we did mention a poor diet and it was right at the bottom and we sort of mentioned it was like, by the way, you need to improve your diet. This now is massive. They're linking most cancers now to a poor diet, which makes sense, doesn't it? The better, what we eat is us in a sense. So we're really, really plugging. You've got to eat well. And sun exposure obviously has been linked to lip cancers. So 2.5 times higher in those with perio, which I thought was an interesting fact. That's why I've bobbed it up there. And you're 60 times higher to be at risk of a mouth cancer if you've got 6 or more teeth missing. I think my brain with that fact is looking at probably, I suppose if they say you've got 6 or more teeth missing, you may have had poor dental health previously. Does that make sense? So I think that's probably where they're going with that. But you are at the risk more if you've got 6 more teeth missing. And oral cancer is 70% more common in those who have had a history of the disease. And we'll see one of my case studies shortly of a guy who had a recurrence. I'm sure you know who it is. Some of you have already seen my presentations. So the signs and symptoms, again, I would hope you would know all these ulcers that don't heal within 3 weeks, pain and discomfort in the mouth, lumps and swelling with no obvious cause, bleeding from the mouth or throat that's unexplained, changes in texture, roughness and hardness, red, white patches in the mouth, teeth that become loose all of a sudden, persistent hoarseness or changes to the voice, difficulty in swallowing or pain, and unexplained weight loss. I always say when I'm on the mouth cancer stands, because we support the mouth cancer stands across the UK now. The mouth is just skin, and I think we need to get back to the fact that this skin here in my mouth goes right the way down and comes out the other end. Yeah, it's got a tongue, it's got teeth, but ultimately it's skin. And you can get cancer. If you had a cancer anywhere else in the body, you'd be looking for things that changes. You'd be looking for things that didn't feel quite right or didn't look quite right. We tend to overanalyze, everywhere else we analyze it and think, is that all right? With the mouth, for some reason, we don't. And it always surprises me that we don't, because we should be able to catch it earlier. Again, that's where I think we come in as dental nurses. These are signs and symptoms for the elderly. I've got a video, hopefully it will play on this shortly. Numbness or tingling in the lips or tongue. And you're going to say, how do you know about that? Well, how can you see that? I've got a little old dear who is actually keeps flicking her face because it's tingling. She thinks she's got a fly on her face. And then we have looked in, and she's got a problem that's a fungating tumour further in. So anything that it's not quite right for them, dentures that suddenly stop fitting properly, that's a massive, that one. If all of a sudden the denture starts rocking, but it just doesn't fit right, could be a mass. Attention should also be made to the face and neck. So we educate staff in the care homes, new swellings, spots or moles that are getting bigger or bleeding, and changes the colour or texture of the skin. These are a real big one. I think in the past, I've been guilty of this as well. We've fixated on looking in the mouth, which we should do, by the way. I'm not saying we shouldn't, but we should be looking at the face as a whole. I hope you agree, just to see if there's anything different. If they're holding the lip in a different way, they're drooling, anything like that could be a sign that there's something not quite right in there. Here are some pictures. I'm sure you've all, this is not very nice for 7:15 on a Wednesday night, and I do apologise. I hope nobody's partners are looking over the shoulders at these. The top left one always, all of them, in all fairness, I always ask myself, how does it get to this, how does it get this far? How does that individual not know that it's a mouth cancer, but they do. I don't know whether any of you have ever had somebody with breast cancer. I know when I worked in the hospital, they would come in with fungating breast tumours that they've just been covering up and trying to ignore. We look at these and think, I mean, how have they let it get like this? But we know that some of these are dental phobic. We know that these, can't go to the dentist. They just don't want to go to the dentist, or they'll bury the head. When it gets to top left, we're going to struggle. In fact, we're going to struggle with a lot of these. This is why we have to get out there and educate on the early detection, because at least we can see them. That, the smell alone would be a sign that there's something not quite right in there. So what's the treatment? Surgery, you'll know about head and neck, radiotherapy with brachytherapy, chemotherapy. We also have targeted proteins that work on the surface of the tumour, and that's sometimes used in combination with radiotherapy. It's got less side effects. I don't know if you've heard of the photodynamic treatment, which is a light sensitive medicine, and then a light source works on that. Those are particularly for skin cancers. I know we do them up here at in the Christie. So this is the treatment for mouth cancer, which I'm sure you're all aware of. MASC, I always put this in because I think it's so important. Please have a look at MASC, Multi-Association in Cancer Care. Have a look at MASC. They state the inclusion of dental professionals is vital throughout the treatment and follow-up phase of cancer treatment. I'm going to be cheeky and say that while we're doing this talk, can we talk about all cancers? Because although this is a mouth cancer talk today, how the mouth suffers with chemo is the same. It's worse for head and neck patients because we attack them with radiotherapy as well. But some of you might have seen the mouth of a breast patient who's been on a treatment that's going to give them a sore mouth. They too need a dental professional right the way through their treatment. Again, I think this is where dental nurses should be involved with all cancers, with all people, all individuals who are going through cancer. So what they're saying is really they should be at the beginning and helping them right the way through. And I hope you agree. It sounds common sense, but it doesn't happen, as you well know. It doesn't happen with some head and neck patients who really need it to. Prior to cancer treatment, prior to the cancer treatment, ideally, a comprehensive oral evaluation should take place 1 month before the cancer treatment starts. That's utopia. That's like, if we could have that, that would be absolutely brilliant. I used to work with the breast team at Royal Oldham on an MDT. So when they had the patient came in for an MDT appointment, I would be there and we'd counsel the patient about their oral care prior to everything else happening. And again, I believe that a dental professional, albeit hygienist, dental nurse, therapist, could be part of that conversation. With head and neck, obviously they need a comprehensive oral evaluation, because what we do need to do is look at, are there any teeth that need to be removed? If this has got to be done 10 days prior to cancer treatment. It's dead flippant, this, because I've stood in rooms with them at Max Facts and gone with an OPG. I can tell how old I am now, guys, because it was an OPG for me, which do you remember Judy smiling? You used to slip it up, didn't you? And there it was. And you'd go, that's got to go, that's got to go, that's got to go, that's got to go. Where's the empathy there? Because you're just removing teeth. And no matter what cancer I had, 1 in 2 of us is going to get a cancer. If somebody said to me, you've got to lose that tooth, that tooth, that tooth, I can tell you now, guys, that would be as bad to me as the cancer treatment. Honestly, it would. Because what I think mouth cancer does is it robs them of their identity as well as anything else. So I really have had to give my head a wobble when we are taking teeth out, because we're taking the teeth out because it's going to give us less problems and them less problems in the future. But we should be aware that that is robbing them of them. Those are their teeth. Caries' teeth need to be restored and stabilized with appropriate restoration. Remember what I said to you before, this is utopia. This is if they've got a dentist. You think back to the other slide, a lot of them have got maybe smokers and drinkers, and have had 6 teeth removed, maybe they don't have a dentist. Maybe they've not been going to the dentist. Hopefully this will be done within the Max Facts department if they've got a dentist in the department. All sharp teeth and restorations are adjusted and polished, and stress the importance of effective oral health. Some of you who follow me on, I made myself sound like something with some celebrity. Some of you follow me on social media. Some of you might have seen that I've just done the Manchester Half really badly. I threw myself around that course, and I did it for Age UK. There's a method in my madness telling you this. I had to train for that marathon, believe it or not. I had to, for weeks and weeks and weeks and weeks, I had to train because I thought if I just turn up, I'm not going to do very well. In fact, somebody passed away actually on that course. The same is with oral health. With prior to cancer treatment, you want to get them a few weeks before, get them cleaning the mouth, because we know that the cleaner the mouth is, the better they're going to do while we're attacking them. And I keep using the word attack because that's what one of my patients said. It feels like you've attacked me here. So stress oral health. The better they keep their mouth cleaner, the better they're going to do. It's not rocket science, that, but I think this gets missed. I really, really do get. I start them on saline straight away before we've even given them chemotherapy, because it gets them into the mindset of got to do that. And you can only advise them what to do. Does that make sense? You can only give them you can only give them the info that they need. But for me, cancer treatment is like getting yourself ready for a marathon. So it's handy that I did one, innit? So I can sort of relate to it. Anyway. The patient is counselled about denture wear during therapy. Again, it's important this. Patients should be encouraged not to wear the prosthesis during cancer treatment and not to wear it at night. Massive. I don't know whether my dad would do that. I've never seen my dad without his teeth in 53 years. I don't know whether he'd do that. Again, we say this to our patients. Do we empathise with them that maybe that's going to be a massive thing for them? But again, this is what we'd like them to do. But even I just get them to even leave them out for a couple of hours a day if the wife nips to the shop or the husband's out. Even if you could just leave it out for a little bit, meeting you halfway. Yeah. It's important to ensure that it's clean and well adapted to the tissues, because you'll find a lot of these dentures are quite old. We also know that they're going to lose weight, don't they? We know they're going to lose weight through the treatment because they might not be able to eat. The shock of cancer treatment can make people lose weight as well. So then we need to be making sure that that denture is fitting correctly. Put counselled about denture cleaning, because you'd be surprised how many people don't clean the denture. They also, a colleague, Amanda, if she was here, would say they don't clean the denture brush and they do not clean the pot that the denture's actually placed in. They just rinse it. If you put your fingers around a denture bowl, a denture pot, you'll feel the biofilms in there. So I don't want them. I don't want those biofilms on those dentures, especially if they're going to get a fungal infection, which I might give them because I've dried the mouth out. I'm rabbiting on, aren't I? I'm sorry if I'm too overexcitable about this as well, but you can feel my passion for it. During cancer treatment, we avoid treatment wherever possible. Not the mouth sore. It's better just to leave them to it, because they might bleed easier. We just want to avoid them where possible, which is why I'm saying let's get them fit before we go for them. I'm sending it like we assault them, really. Alcohol-free chlorhexidine mouthwash is recommending if toothbrushing is likely to be a problem. I know myself though, it's great chlorhexidine. Other brands are available, but you might have to dilute them 50-50. So just be mindful that can sting the mouth. I'm a saline girl, so I would prefer that we're cleaning the skin as well in the mouth. So the Chlorhex will do the plaque around maybe the denture, the teeth. But what would you clean skin with? What would you clean a wound with? You would clean a wound with normal saline. And I think we don't use warm normal saline enough. Mask again recommends that it will not prevent oral mucositis in head and neck patients. Chlorhexidine. My personal experience with Chlorhex is it's the first mouthwash of choice. I would like us to try thinking about maybe a warm saline if we can, especially when they've got a sore mouth, if that makes sense. We can speak afterwards if any of you want to ask me questions about mouthwashes and stuff, but I'm fairly old school where that's concerned. Again, if any patients are having the bone marrow transplantate, they are really at high risk of dental caries. So basically, we'll give them dietary advice and maybe some fluoride supplements, preempting it, an alcohol-free fluoride mouth rinse at least once a day at a different time from brushing. In addition to I nearly said the net. I'm going to say it, Durafat, 5,000 parts per million fluoride toothpaste. Some patients, however, suffering from oral mucositis, which is a sore mouth, will not be able to tolerate the fluoride mouthwash and toothpaste. So often they would come in during therapy, during treatment, and our consultants say, "Are you using the toothpaste?" And they'd go, "Yeah." And then they'd go outside and they'd say, "No, I can't, it's too strong." What we did then, again, or what I did with my role is I would say to them, while the mouth was sore, I would get them on a foam-free toothpaste on the understanding that once the oral mucositis has settled down, they're back on the 5,000 parts per million. Does that make so? I don't. It's just being honest with them. I'd love you to use the 5,000 if you can, but if you can't, I'd like you using at least a 1450. At least you're getting something in. Because we've got to keep that mouth clean. We really do have to keep that mouth clean. So it's about sort of having a chat with your patient and sort of getting them to be honest with you, and you're honest with them. Look, I'd rather you use at least something. They are at risk of fungal infections, and that goes for anybody who's undergoing cancer treatment for whether it's head and neck, breast, lung. They are at risk of fungal infections. So topical agents may be preferred rather than the systemic agent due to the side effects. You've got to change that toothbrush regularly, every week if possible. What I do, if they're a home patient, don't do this on the wards because there'd be so many toothbrushes. We'll have a blue one for morning and a pink one for night. So we'll have two brushes going, so at least they dry out. So if they dry out, you've got less risk of a fungal infection rather than keep changing the toothbrush. You with me? Treat the denture with the antifungal agent. And any of you have seen me before will know if they've got a thrush in their mouth, fungal infection in their mouth, and they wear an upper denture, a lower denture, the fungal infection goes with the denture. It doesn't stay in the mouth, it goes with the denture. So we're all treating the mouth. However, the denture's got the fungal infection in it. So if you've got a good consultant or a good dentist, get them to prescribe the nystatin, for example, and treat the denture with the nystatin. Tea tree oil mixed with co-comfort tissue conditioner has an antifungal effect. So that's just a little tip. I remember co-comfort was I had to mix that. I can smell that now. Just as I'm looking, I can smell it. And some of you, I'm quite old though, but it does have an antifungal effect. I would stress also that if you've got somebody with a fungal infection that's not clearing up, could you ask the hospital or the department to do a microbiology swab just to see what it's sensitive to? So, for example, if I go to the doctors tomorrow and I think I've got thrush down below, they will examine me, they will treat me with something, or they'll probably swab it just to see what it's sensitive to. It could be it needs a different antifungal treatment rather than the nystatin. If patient is using chlorhexidine and nystatin, wait 1 hour between each of them. They don't like each other, those two. They counteract each other. So especially on the wards, that becomes a problem because they'll give them at the same time. But if we can wait 1 hour between, that would be great. Your mouth might get a little bit sore. My argument with this is if this was anywhere else in the body, tissue viability would be going in, district nurses would be going in, dressing it, cleaning it. Are you with me? But because it's the mouth, it's just, well, you've got to crack on. You've got to eat, you've got to drink. I mean, this is sore. This is particularly sore. And oral mucositis can lead to severe pain, which impacts on patients' ability to speak, eat, and drink. You've got increased risk of fungal infections, and patients may need to be enteral fed. And more importantly, they may have to have unplanned breaks in the treatment due to the mouth. So if I knew they were going to be put on a chemo or radiotherapy, I would say to them, your mouth is going to be very sore. I'd know, like I've just said to you before, if they had poor oral health, I knew I was going to be up against it because they're going to get a sore mouth. I'm not saying I'm Mrs. I was born with a toothbrush in my mouth. Sorry, I'm on a main road. But my mum was a dental nurse, so me and our kid have got clean mouths, obviously, because she was obsessed with it. If I have to go under cancer treatment, I hopefully will hope that my mouth won't suffer as badly as somebody who hasn't been looking after their mouth, but still know I'm going to get a sore mouth. So it's sort of managing that and having empathy, but being frank with them, saying you're going to get a sore mouth. Please don't say it might get a little bit sore, because the sore and the sore, that's more than sore. And if we had a nurse who was a nurse at clinic, or if we had a nurse that was around when this was happening on maybe clinic, like I say, this could be explained to them, because to enteral, to put a peg in or a rig in to feed them, and if it costs money, by the way, it's more for the patient, but this then starts costing money. They have to come into hospital, they're at more risk of catching an infection while they're in. They may have unplanned breaks in their treatment due to the mouth. We don't want that. We want them to get through this chemotherapy treatment and hopefully get on the other side. Look, it's so debilitating. It really is sore and horrible. And if we had smelly vision, you could probably sort of smell that. Can I just say as well, the elderly, the young children, used to live in a very rough area, me. The elderly and children really suffer from oral mucositis because the children replenish their tissues quicker. So it's not healing at all, and it's even rawer with kids. Can you imagine trying to explain to a child this kind of level of pain and open wounds in a child is really, really difficult to treat. It really is. So please, if you have got somebody with oral mucositis, please meet them halfway and let's look at how we can get them through it, because it will go, but in the meantime, it's very, very sore. Oral mucositis pre-warned and pre-armed. That's what I'm saying to you. I'm not saying I sit there like the Grim Reaper with a scythe going, it's going to be awful. But I do sort of say to them, it's going to be a bit challenging, this. Inform the patient fully of the effects of oral mucositis. Stress the importance of good oral hygiene. Assess the mouth prior to treatment. I've just said that to you. You know it's going to be okay if they've got a clean mouth. You know you're going to be up against it if they maybe aren't up to up to scratch with their oral hygiene, and offer products to help with the symptoms. Hopefully some of you will have seen something called Gelclair, which is the liquid plaster for the mouth. There's also Cafosol. There's a new one out called Gel-X. If anybody would like any information on Gel-X, will you email me or pop something in the chat? It's just that I met the lady at the Swallows conference, and I'm really impressed with Gel-X. It's licensed to prevent oral mucositis and treat it. I had somebody in the hospice, unfortunately, who's passed now, who had oral mucositis, and it actually got her through the last few weeks of her life, and it actually helped her mouth. So that's Gel-X. And the lady who is the rep for it is brilliant. And you know what? She'll come into a dental surgery. And you don't have to work in a hospital to be dealing with people with oral mucositis. She will come and see you. And I think as nurses, we should be up to scratch with all these new products that are coming out. By the way, I'm not I'm not getting any money from Gel-X. I'm just saying I think it's a really, really good product. Cafosol is excellent as well. It's licensed to prevent oral mucositis. But have a look at what you've got. Difflam's brilliant. I will always use Difflam spray. You've heard of Difflam spray. You can spray it in and it numbs the mouth. So yeah, there's various ones out there. And grade the mouth and reassess regularly. I'll talk to you about grading when I show you the pocket guides in a bit, so you can understand what I mean by grading. Post-therapy. They're at risk of uncontrolled dental disease following treatment for at least 12 months. I've got to say, I think that's lifelong, and I've put in lifelong, but a lot of the evidence says 12 months. I'm seeing it years and years and years afterwards. It's an ongoing thing. I know if Fiona was here now, she'd be saying the same. Why these people with head and neck cancers have to pay for their own dental treatment post 5 years when they've been discharged from the Max Fax team? I'll never understand why they've got to find the money to pay for their own dental treatment. And that is something that we are dealing, lobbying Parliament for at the moment. They should get help. They should get support, as do anybody else who's got any other cancers do. If they're on cyclosporin, they might, because they've had a bone marrow transplant, they'll get gingival hyperplasia. So they need to see the dental hygienist regularly. Again, that's something I think needs to be explained to the patient before it happens, because when gingival hyperplasia starts showing themselves, they have no idea what's going on. But that's something that's really important because that helps them maintain their oral hygiene. The fluoride regime should be decided by the patient on GDP and dental hygienist. And xerostomia is the most complained side effect of treatment mentioned after all the surgery and therapy has been completed. Got a guy, a young bloke who we treated, who actually said he wished we'd never attacked him because of his dry mouth. Judith Gens nodded. I cannot tell you how this affects them. It must be awful to have this mouth. We are doing targeted proton therapy. We're doing loads of targeted therapy, radiotherapy, but they still end up with a dry mouth. And we try and preserve the parotids as much as we can. But they also, even if they're left with some parotid function, the saliva changes. It's never the same as it was. And honestly, please have some empathy with xerostomia. And it doesn't matter. I'm smiling now because some of you know who I work for. It doesn't matter what we prescribe them. It'll never improve it 100%. It might improve it 50%. And I feel in my job that I say that to them. Listen, it'll improve it probably about 50, 60%. Other companies and other products might say otherwise. I honestly don't think it does. But if you say that to them, they're not expecting it to get back to normal. Again, I think with the mouth, people and patients expect it to go back to normal quickly. If they had breast, if they had bowel, if they had any other cancer, they'd be left with the legacy of that. Flipping out, you break your leg, you might have a problem, might get rheumatism in it, or might be left with a limp, but you're aware of that. Why is it with the mouth? We just expect, boom, back in the room, it's back to normal again. You've got to be honest with them. Here's a guy who I saw about a year afterwards because we weren't sort of reviewing them, to be honest with you. I might not look too terrible to you there, but look, he's got no saliva. He's got a little bit of saliva, but you can see yourself all this build up, and he's going to end up problems. Can't have a tooth out in practice because of the osteoradionecrosis risk. So by seeing us, by seeing a nurse on a nurse-led clinic or a nurse in the practice, we can hopefully prevent the fact that he might need, if he runs into problems, he's not going to have a tooth out. But it's a perfect storm, this, because you've got a partial, and it's just, it was covered, the back teeth were just covered in it. He needs to see somebody. He needs to see somebody to talk to him about how he's going to clean his mouth and maybe use a saliva substitute. Again, toothpaste, I only use sodium lauryl sulfate free. Again, I think you'll all hopefully agree with me on that, purely because it empowers me more, that I can see what I'm doing. Back onto the elderly, I brush my mum's teeth now, and I say to her, spit out. My mum doesn't know how to spit out because she's losing the capacity for that. She hasn't got a clue what I'm talking about. So we have to use a non-foaming toothpaste. It does reduce the risk of an aspiration during oral care. Some of them will have dysphagia after we've attacked them. Maybe they've had part of the tongue removed or the swallow is compromised. So an SLS-free toothpaste. Sensodyne, I believe, are taking their SLS out of many of the toothpaste. I think there's only two that have not got SLS free. Have a look, you'll find them are all there. You've got your tooth mousses. I've had to mention I've had to mention Oranurse, sorry, because it's unflavoured, and there are other unflavoured toothpaste now out there, but that's the toothpaste I will use if they've got a sore mouth, because it's not got any flavour to it. bearing in mind all of these, apart from the Durafat on the right, hasn't got the right amount of fluoride in that they need. But it's just getting them through that sensitive air, that sensitive time. Okay. The role of the dental nurse, that's me. We did this again, said this on Sunday up in Scotland when I was with Diane. I just don't understand why we're not getting Macmillan oral health practitioners everywhere in every trust and in primary care. It doesn't have to be to a hospital. It could be attached to a dental a doctor's surgery, a practice. We should be there helping these patients because I think it's cost effective. While my time at Pennine, sorry everyone, at my time in Pennine, they did a review of specialist nurses, and funnily enough, I was that's a specialist nurse uniform. They classed me as specialist nurses because they were looking to maybe cut teams down because the breast team was huge, the lung team was huge, and guess who came out that she was saving more money than any other nurse? Was the oral health practitioner. Discharges, people weren't having to have pegs. I'm not saying it was, I was doing fantastic work, and everyone was surprised by it. I think we can do this, and I will keep saying this. Fiona's probably sick of me saying it. I just think there's a role for us, and I just think there is a role. Maybe if they don't want to do the Macmillan oral health practitioner, there is a role for an oral health practitioner linked in maybe with dietetics and with speech and language because it is so important to keep the mouth clean, and it will reduce systemic conditions as well. So that was an article that was written for a nursing journal rather than a dental journal. And again, some of you might have seen this slide. It was a case study about this guy. That, ladies and gentlemen, is an inside of a mouth. This is where we go wrong, I think. This is post-treatment. This is what he's like when he's at home. This is how he's been thrown out of hospital and his mouth's ended up like this. He's no tongue. We've whipped his tongue out, so he's peg fed. So he'll never, his tongue's gone. There's no saliva due to radiotherapy treatment. His wife and himself are discharged from the ward with a portable suction machine. I don't know whether any of you have ever seen a portable suction machine for home use. It's not like the ones we use in practice. It's not like the ones the Yankee suckers we use on the wards. It's not got as much power because it's being used at home, but it more or less is the same as what you and I would use, less powerful. I had to train. I don't know anybody else if everybody agrees, but I had to train many, many years to be able to use a Yankasucker on somebody. And in practice, I had to become, classed as competent to use suction. Yeah. I know some of you nod at me, but yeah, that it makes common sense that we have to know what we're doing with that suction machine. Yeah. We've discharged him and his wife home with this suction machine and said to his wife, there you go. He was shown how to clean the peg. She was shown how to look after him, but she was not shown how to use the suction machine. It's horrific. She's cleaning, she's actually removing his crusty plugs in his mouth with eyebrow tweezers. So when she's pulling on on these crusty plugs, what's happening is it's bleeding everywhere. The odor from this guy's mouth was the worst. Even years later, I can still smell it. It was absolutely awful. He'd taken to his bed. District nurses were coming in. They wouldn't touch his mouth because that was outside their remit to do his oral care. That hasn't changed, by the way. It depends on where you are. That oral care isn't part of their remit. I'm sure some of you are shaking your heads and going, well, that's not on and blah, blah, blah. I sort of understand what they were saying about this because the anatomy of his mouth, as you can't, when you do your suction and you can go to maybe the distal of the last molar, you go there, you'll depress the tongue. There's no anatomy there. You can't even see where you're going with it. So I struggle. So what chance have they got while he's in bed with no source and a suction that's really quite weak? My problem with them was they never fed it back. No one ever got in touch with us and said his mouth's a mess. And they would have done if it was his peg. They would have done if it was somewhere else on the body. And we actually picked him up at intensive care because he nearly died from a chest infection. So what happened then was I reevaluated what, because I felt I was to blame as well. I was, because I'd not been called down when he got discharged. I should have made sure I was down there. I then lubricated his mouth weekly on a nurse-led clinic. Again, a nurse-led clinic. You can see the bottom there now. I mean, I know I need to get out more, guys, but isn't that beautiful? It's just, it is. And you come on, you know it is. You know it is. I know you think I'm odd, but beautiful that. I mean, it's gorgeous. His flap's clean there. I have to pluck it every now and again because it grows hairs. Oh, we've shown Gloria how to clean it, his wife. By keeping his crusty plugs moist, it lifts off easier. He's managing it. He can actually tell me to go away with a word that begins with F. I won't go into that because we're being recorded and I'll get struck off from the GDC. But he can now tell me to go away. And when he did say that to me on the phone, I cried, not because I was upset that he sworn at me. I cried because in the human body, brilliant. How he's actually starting to try, he can actually communicate to me without a tongue. And do you know why he can? Because his mouth's not like that anymore. Yeah, this is what we could do. It wasn't rocket science, guys. It was just sitting with him and just getting him confident that, because it takes a bit of trust to go into somebody's mouth when they've not got a tongue. It's dicey. He's never had a chest infection. He's had a heart attack, but that's not my fault. He's not blaming me for that. His mouth's beautiful. It's beautiful, and I love the bloke. I love him to distraction. And the odour's gone, and his quality of life has greatly improved. Um, it's improved, but his life will never be the same again. And when I read my poem later, I want you to think about Peter, because the verse, Judas heard my poem, but I sort of wrote the poem with Peter in mind. So just do it in a minute. Oh, I'm emotional because of not being able to get my computer on enough. And then he pops up, Roger. You lot who know me know I cry when I see Roger because he's just my boy. Um, he was a patient. He was my last actually patient ever at the Penn Acute Trust. Because I left not long after Roger. And I struggled after Roger, not as much as his family, but he had a profound effect on me, Roger. Roger was an electrician. He was a massive bloke, guys. He was a huge big black guy. He played rugby league because we're up in the northwest. 6'2", built quite. He liked to drink, did our Roger? And he got like complainers, and it turned nasty. And we attacked him with surgery, radiotherapy, chemotherapy, and we thought we got it. We thought he was going to do all right, Roger. But do you remember me saying, you've seen me before? Sometimes when you prod a cancer, it's like you're prodding an animal, and sometimes it comes back a little bit more frost than it did before. And it came back, and it did that to my Roger. I have vowed my voice doesn't, when I stop crying, because I do get a bit emotional with Rog. I vowed when I stop getting emotional with Rog, I'm not going to do my job anymore. I'm not going to do these talks anymore because he- he's a human being, this guy there. Look at his eyes. Look at his eye. He died the afternoon of this photo. This puts it into context. And he was still letting his daughter take pictures. You know why he let her take pictures? Because he didn't want somebody to go through this afterwards. And he knew he was dying. He knew he was going. And I went in to see him, and we'd always promised that we'd go for a drink, me and him, once he was fine. Because I like JD and he likes JD. So he said we'd go for a drink. Some of you are probably going to say to me, you shouldn't be condoning drinking with elderly patients, but you know what? I'm of the opinion with them, especially if they've got recurrence, let's let them have what they want. And I walked in and he was really upset. He'd just been crying. I don't know whether you can tell by his eye. He'd been crying because his grandchildren wouldn't go in and say goodbye to him or give him a kiss. So I went and spoke to the grandchildren. What's the matter with you? Go and say goodbye to your granddad. No, his mouth's sticky. And it's funny because we were all obsessed with this tumour here, because we were all fixated on the tumour. What we'd not done is looked in his mouth and looked at his mouth. So I said I lubricated his lips and they were able to kiss him goodbye. So I went in to say goodbye to Rog, and he went, "Where are you going?" said, I've got to go, pal. I said, you've got your family here. He said, I want you to do something for me before you go. So I thought, he wants me to get a straw. We'll go and have a drink together. Even though I was working at the time, but don't tell anybody. And he said, no. He said, I want you to brush my teeth. And I looked at him as if to say, are you sure? Because I knew he was dying. I beat myself up about this because I'm only human though, because I thought, well, you need your teeth brushing. And he said, I know what you're thinking, Em. He said, but I want to meet him with clean teeth. And God bless him. This is what mouths mean to people, isn't it? Right in the death, his mouth killed him. That's what's happened. It's his mouth that's killed him, but he still wants to meet him upstairs with clean teeth. So I did. I cleaned them as much as I could, and I had to use an unflavoured, non-foaming toothpaste. And he did meet his maker with a clean mouth. And that's all that matters to me. His daughter, by the way, is still traumatized 12 years later from this. And I think what we should remember as nurses, as healthcare professionals, is that this is somebody's father. This is a human being, and this has disfigured them. That doesn't look like granddad. What you can't see in this photo, it really is his inside eight in his clothes at this point, and there were flies flying around this as well. Horrific. We pride ourselves that we give our patients a good death. I don't think we gave Roger a good death, but that wasn't anything we'd done. It was just this awful, awful disease. I'm depressing you all now, aren't you? I'm very, very sorry. I wrote this up for a journal. Please, if you're not a member of the SBDN, come and join us because we love articles. We want you to write articles, whether you work in practice, community, hospitals. We should be writing articles about our experiences, and we will support you doing that. The reason why this was cathartic for me, because I'd got really cross because he'd been into a certain chip shop chain, and I'm not allowed to say who they are. Read the article and you'll find out who they are. And he was asked to leave because he was upsetting the other people in the restaurant. And it didn't look like that then. I could understand it if it looked like the slide of just, but he was dribbling just a little bit. And he was asked to leave, and he was so cross. Do you know what? I was really cross. And he was saying to me, this was months and months before he passed, people would pass him, people would cross the road to not look at him. So I wanted to write that in an article so that people understood what they're going through. Other cancers we can cover, other cancers we can shield away. This cancer that we're all involved in, that we battle with every day, robs them of them. Yes, says getting upset. We've done pocket guides, me and the team. I don't know whether you've seen these pocket guides. We've done some resources. These are the oral care pocket guides. They are a tool, basically. I don't know whether you can see them. Anybody who'd like the PDFs of these are for care homes. You can actually do this. You can have some of these anyway. And you can see the trick. Basically, it's not a diagnostic tool, guys. Tell them what the care is. I think they're pretty good for care homes. We've the society have endorsed them as the Mouth Cancer Foundation. They are available on NHS supply chain now. I've got them on the supply chain, which I'm really proud of. You have to, if you are going to purchase them, you just purchase in the printing cost. Society and everybody else don't make any money. These are mine and Amanda's work. They've actually just won an award at the Gerodontology conference last year. So there's the blue one for care homes. The green one is for anybody who's working with patients with oral mucositis. You know, I mentioned to you before about oral mucositis. And it's basically a grading tool. I'm sorry, because I'm on this laptop. So you've got grade naught. You grade the wounds in the mouth, grade 1, 2, 3, 4. Actually, there is a 5th grade, which is death. I use the WHO grading system, which looks at diet as well as what you can see in the mouth. If you want some of these, please let me know. I've also done a leaflet there for mouth cancers for the elderly. So please, if you do deal with care homes, could you encourage them to go on the Mouth Cancer website? And if you have got care homes where you work, if you're working in a dental practice and there's some care homes, get them to do a board in November on mouth cancer awareness. Because not only are you educating the staff on how to look after the residents, you are also getting them to look in their own mouths at the end of the day. So these leaflets are there. And what we do with the elderly is look, listen, and observe. Where's that? Hang on. I'll tell you what I'll do. Is this going to play? Have a listen to this first. I'll come back to that. What's it doing? Hygiene is important.
Emma, Raluca's
The
saying
video
she
not
can't.
playing.
We can see the video, or I can,
Oh.
but there's no sound.
Can you not hear my dulcet tones, you lot? Oh, it's great as well. I'll send you the link for that. So basically, oh, it's not a very good shot of me, is it? To be honest, let's go back off that. That's horrible. Sorry guys. The care home, I'll send you out the link. I don't know why it's not playing, but we did go into Rochdale and we did a look, listen, and observe for mouth cancers. So basically, what we're saying is make sure you're looking and listening and looking to see if there's been any changes around them. It's a really good video, to be honest with you, when the sound's there. Like I say, Nicola, can we put the link somewhere so they can have a look at it maybe at some point? I'll send it through to you. But
Yeah,
again, if you know any care homes, if you know anybody who's working with the elderly, would you please share it with them? Because they are the group that are most at risk. I'm sorry about that, guys. It was dead good, that video as well. And when Peter, when you're not with me, have a look at Peter, the guy who's in the video, because he's a resident from this home and he got well into it. He needed a BAFTA by the end of it because he was tending to be in pain and everything. So please have a look at it. We've also put together head and neck cancer pathways for Rochdale, but again, if anybody wants them, they can be used in other places as well. So if anybody's getting discharged from a hospital, there's a pathway so they don't get missed. I've also done one for oncology patients as well, if they've had breast or anything else. To improve their care. So what we're trying to do is nip in the bud any problems before it's any worse. I mentioned to you that's Amanda, Present Radio. That's myself at the launch down in Parliament of mouth cancer awareness. As dental nurses, we can all get involved in this. We can all get involved at launches. But please, I know I keep going on about the elderly, but it's horrific. You might not be able to see this link, the one on the left, but I'm going to read you now what the manager at the care home, her experiences of this. A resident that currently resides with us brought to my attention that her mouth was sore. She had taken out her denture and had tried to scrape off denture fix with her fingernail. To taking a closer look, I found out that there looked to be an abnormal structure in her mouth. I asked the visiting healthcare professional to look and advise me further. He told me that it was imperative to get a GP to see it as it looked like it required further investigation. I contacted the GP surgery to be told by the receptionist. As it was a mouth problem, she had to see a dentist. I wasn't happy, as the resident also stated that she was finding it a little difficult to swallow. I mean, I contacted the GP again and demanded that they came out to see her. The GP arrived and again stated to call the dentist. You can't do anything else. Ring 111. I rang 5 local dentists, explained how important it was that this lady was seen. I explained that she had poor mobility and needed a domiciliary appointment. Not one dental practice would accommodate her, as none of them had got a domiciliary contract and they had no insurance to do this. I stated that this was important and I was prepared to pay private for an emergency appointment and book a wheelchair, but they all said no. Even though I explained that this lady finds it very difficult to leave the home and it would cause a distress. We felt we needed her to see a professional, not one single practice. Why? Why are our elderly second-class citizens? Are their mouths, gums, teeth, or health not as important as others? After 2 further agonising days, we managed to get an appointment with the emergency dentist. As this was ongoing, I am unable to share further information, but an urgent referral had been made to our resident to have a further exploration. Now, you'll often find, sorry, I'm nearly done, I promise. You'll often find that what happens with this is that the dentist says it's the GP's job and the GP says it's the dentist's job. Some of you might have had this before. Again, there is a human being at the centre of this. We can't do anything for this lady. This was weeks between, and it completely overtook her maxilla, this tumour. She did pass. We managed to keep her in the care home. We got district nurses to come in because she was being peg fed towards the end. The main thing was, I am just doing a care plan for how I want my mum and dad to pass. She'd actually put that she wanted to stay in her home. I didn't want her dying in a Max Fax ward. Didn't want her dying in A&E. We managed to keep her at home. What we ended up doing in the end was just taking her down to A&E, unfortunately, just so we could get some pain relief so they could manage it. This should not happen. I hope you all agree. If this had been me at 53 or 54, I don't know why, it would, I know, Lindsay, I don't even know how old I am. I would have got treated. I genuinely think that it's because they're elderly that people think sometimes just leave it. And it should not happen. Sorry, I'm on my soapbox again. Although we don't want to see that again as well. If you want the slides, I'm sure Nicola and I could do it in the PDF and send them out. If anybody's interested in them at all, please have a look at the Mouth Cancer Foundation. They have got loads of facts and figures and loads of things you can print out for your boards and your practices or on your wards. There's UCOMIC. I was part of UCOMIC. They've got loads of resources on how to look after the mouths of patients or individuals who are suffering from cancer. I've also done, she says, I don't know whether you can see that. Can you see it? Can you see it? If I do that, can you see it? See it? So this is a QR code. If any of you want these as well, you scan the QR code, and it is for patients who are maybe end of life or palliative, or patients who are poor, very poorly. It's me talking to the camera, as if I'm talking to the relatives, saying you can see your relative's mouth's a little bit dry. Maybe we can do this, this, and this. It's explaining to them why the mouth's dry, why the mouth might be sore. Again, if any of you would like those, please. What we're doing now is we're laminating them and we're putting them in the rooms of hospices or in wards or in residential homes so that the relatives can actually scan it. Palliative patients do struggle with the mouth. Can I just stress before I go, palliative does not mean imminent death. Palliative can mean 2 or 3 years. But having sat and cleaned the mouths of people who have died, the relatives do feel a bit inadequate. They feel redundant. I wanted something that empowered them to maybe look after their mouths. So if any of you'd like those, please let me know. Unless you can get, or you've missed the one show, but there'll be something else on, no doubt. Listen to my poem and think about Peter. Let me introduce myself. My name is Mouth Cancer. I'm not as well known as my other brothers and sisters in our family, but I'm no less dangerous. Sometimes I will call on you without notice, but in some cases I'll give you an idea that I'm going to visit. The legacy of my visit will often linger with you and your family for years to come, even though some very clever and caring professionals, that's us, will try and help you move on and try and forget me. Although not invited, I'm the guest at every meal you'll ever take. I'll dictate what you eat and whether you will enjoy it. I'll decide if you go out for that special meal or that night out with the girls, just a dry mouth. One of the things I'll leave you with after I've been, and red wine may be a problem for you from now on. My visit also touches your family and friends too. Although they don't want to, they may look at you differently after I've gone. But my shadow will always remain if you let it. I'm third party in your marriage or relationship. Whenever you kiss your partner, it will be me you think of, not them. And finally, if you let me, I will dictate if you smile or not. Because when you do smile, you will always be thinking of me. And people can still see where I'm visiting. Of course, those clever people at Action will try and stop my visit if you let them. And they will also help you erase my memory, even if you visit them before I visit you. That's what mouth cancer, couldn't think of any other way of putting it. Listening to my patients, they do. Everybody, whenever they talk to somebody, they actually think that they're looking at the cancer, not them. If that makes any sense whatsoever. Hope you've enjoyed that. I hope I've not talked too quickly. I hope you've taken something away from it. Hope you don't mind me getting upset when I talk about. I'm so passionate about these people. I think they're heroes. I think they're warriors. I think they are superheroes. I've had patients. They're quite stoic. Don't let anything get them down. But at the end of the day, they're human beings, and we need to try and have some empathy. I'll never understand what they are going through because I haven't got a mouth cancer. I think sometimes to try and put ourselves in their shoes is a good thing to do. Thanks, Nicola. Thanks for having me, everybody. I'm sorry my video didn't play. It was brilliant. It was my acting skills and everything. I think I could do some TV work actually. You couldn't hear me and everything.
Next time, we want you to enact it if it doesn't play. Oh, everyone's saying thank you on the chat if you have a look through. Lindsay says, heard this talk at BAOS
Sorry.
in Edinburgh 2 years
Too
ago.
boring again. System jokes probably and everything.
It's
Sorry.
just as interesting second time round, she says. Very informative. Lots of people asking for the PDFs and guides. Provided
We got everybody's details, Nick. Sorry.
Yeah, I think provided the email that you registered for this event for is your email, I can't see why it wouldn't be. I'll be able to send it along to you.
Is that all right with everybody? I'll send you all the, even if it's stuff you don't want, just if you could cascade it to some of your teams or wherever, if you don't need it, that's fine. And if you're not a member of us, we do this in our own time, don't we, Nick? We're very passionate about the society. Please sign up for us. If you are a member, please get some other people to sign up as well, because together we're stronger as a group.
Members who are on tonight, if you go to our website, go on the events page. If you scroll down, there should be a feedback form. If you fill that in, send it to me. If you want to take a photo, send it to admin, our admin email address, and I'll get the CPD certificates out to you. If you struggle to find it, I will help you. That's it.
And everyone stayed awake, I think.
Well,
was snoring a bit, but
we don't know. We don't know. Everyone was on mute. They might have been snoring. Now we'll get in trouble from the boss now.
I know, sorry. Do apologise. Well, thank you, everybody.
Very much, everyone.
Brilliant. Thanks,
for coming,
guys.
everybody. Thank you. Take care. Night,
Take care. Bye-bye.
Bye-bye. Bye-bye.
Thank you.
Thanks a lot. Bye-bye. Nice to see you all. Take care, everyone. Bye-bye.
Bye.
Yeah, thank you. Great webinar. Thank you.
Thank you. Bye-bye.
See you
Bye.
soon. Bye.